Okay, y'all, we're going to talk about, start talking about dissociative disorders today, which is chapter 19. Okay, so these patients that we're going to talk about, they kind of, you might think they're psychotic, but they're not. There's no psychosis at all with these patients, none whatsoever. So we've talked about the defense mechanism, which is called dissociation, which all of us at some point do that. And that's when you just kind of leave for a minute and kind of go daydreaming, okay? And that's a form of dissociation. It's daydreaming. It's, some of you might have experienced highway hypnosis where you're driving and you're just kind of somewhere else, but you're still driving. Now that's dissociation, but here we're talking about it being a DSM-5 diagnosis, okay? So these are all that I'm going to talk about today are going to be on axis 1. So dissociative disorders, what they dissociate from is several things. They dissociate from their memory, their identity, their perception, because this dissociation allows them to escape from childhood trauma. And that is generally going to be what the bottom line issue is for these patients. It is all, in dissociative disorders, it's all trauma-based. All trauma-based. So what they do is they avoid unpleasant memories by forgetting. The brain walls off the memory. And the brain does that because it's trying to protect them from whatever the trauma event was. Now, they don't necessarily remember the trauma event. Most of the times they don't. So they don't really know why they're doing what they're doing. They might not even know they're doing this until somebody tells them, okay? So the first one we're going to talk about is on the list of dissociative disorders, and you can see there's no hallucinations, no delusions, not psychotic. We've always got to rule out that there's anything medical. Especially, this is one we really have to make sure there's nothing medical going on. So they just have a disconnect, and it's a disconnect between their memories, their identity, their actions, and we'll talk about the different ones. It ranges from anywhere from amnesia to alternative identities. Okay, so the first one is dissociative amnesia. And remember, all of these is, the cause is psychological. The cause is not physical at all, okay? They know that they have forgotten. Okay, so they know they have forgotten. So they have one or more episodes of memory loss. They can have partial memory loss or total memory loss. So you can see here, while we have to rule out medical, we got to make sure that they hadn't fallen, hit their head, had a stroke, something like that. Now, why have they forgotten? Because it's the brain's way of protecting them from having to remember the trauma event. It's another way you can kind of look at it is how your body walls off an infection when you've got an infection. and it walls it off in order to protect the rest of your body. So that's kind of what's happening here. The brain is walling off the past trauma event to keep the patient from having to remember what happened. But as a result of that, there's going to be dissociative amnesia, or a loss of ability to remember things. So they're not going to remember, they might not be able to recall people, they might not be able to recall events. And it can involve complete loss of memory. In other words, the person might say, I don't know who I am anymore. I don't remember my name. So it can be localized amnesia, where it's certain spots in their lives they don't remember, or it can be generalized amnesia, where they forget everything. They don't know their name, they don't know where they're from, they don't know who they are, so they basically know nothing. The next one is dissociative fugue. Now this is an interesting one. This is where the person, let's say the person's name is Joan Smith. That's who she was born. She was born Joan Smith. And one day she wakes up, or she one day just finds herself living in Hawaii, and she's now Mary Adams. She's become another identity. So the fugue part of this is not only do they become just one other identity, they also wander from home. That's what fugue means, to wander. To wander and to forget the past. So they become another person when they're in that fugue. So when she's in Hawaii living as Jane Smith, she does not remember who she was, that she had a life back here in Birmingham. She doesn't remember that. She doesn't even know that she's from Birmingham. She thinks she's Jane Smith that lives in Hawaii. Okay, so she doesn't remember her real self. So she could be in that fugue for years. So she could get married. She could have children. So there's lots of things that she could do, because she could stay in that fugue state for years. She doesn't. Now all of her people back here in Birmingham are wondering what happened to her. But when she's in that fugue, she's another person, so she doesn't know about anything back here. Now, if and when she comes out of the fugue state and her memory comes back, so let's say her memory comes back and she's sitting there at breakfast with her husband now that she married while she was in the fugue state, and her two children, because she's been married, because she's been in the fugue for, let's say, 3 years. She's going to look at them and she's not going to know who they are and why she's where she is. Okay? This kind of stuff does happen.
This stuff you see on TV that you just don't know really is going on.
So when they return to the pre-fugue state, which is, in other words, I wake up in Hawaii and I remember who I am, I don't remember the fugue. I don't remember that I married this man that I'm sitting at the table with, and I've had 2 kids by him.
How long can that last? Can that last for like?
It could last a long time. It could last a really long time. You know, these people that people say just went missing, you know, and we automatically think somebody might have killed them. Well, it could be they're in a fugue and they're living somewhere else. Sometimes they do come back to their original person, and sometimes they don't. Okay, so our next one under dissociative disorders is dissociative identity disorder. And it was formerly called multiple personality disorder, but it's now called dissociative identity disorder. And this is when two or more people are now splitting off from the original person. So this person becomes either two or more different people. So they'll have different names. They can be of different genders. They can have different reactions, emotions, and body functioning. So let's say, and I think, oh God, this, yeah, I do. So let's say this is an example. No, I went backwards, I'm sorry. No, I'm good. Okay. So let's say the host is the person that you're born as. Okay, you're the host. So everybody in here is the host. It's who you were born as. Okay, so the host develops a dissociative identity disorder, or DID. And the three people she happens to turn into, and it could be more than three, but it's got to be at least two or more. John, who is 8 years old, Debbie, who's 65, and Mark, who is 40. So the different personalities control a person's behavior at different times. Who comes out and who stays in really depends. Depends a lot of time on stressors, what's going on in the person's life, if there's a personality other. So when she comes back to the host, she might not know what she's done for the past week. She's going to say, I've lost a whole week. I don't even remember what I did. Well, she didn't remember what she did because she was Debbie all week. Okay? Now, the fascinating thing about this is so the host is the original person that she was born as, okay? And then the alters are what she splits off from the host from. Now, the alter she becomes doesn't have necessarily any rhyme and reason to it. Okay, the fact that she is an 8-year-old boy and a 65-year-old woman, and then a Mark who is 40. Why she splits off into those, we don't know. But if Debbie goes, if the host Debbie, the host Mary goes to the dentist and gets Novocaine, and during that process of getting her teeth worked on, she switches personalities and she becomes Debbie, the Novocaine won't work. So the Novocaine will have not worked on Debbie.
How is it possible?
Because the brain controls everything.
So you give it like, what if it's like they gave her the max amount? Do you give Debbie the max amount too?
I don't know what they're going to do. I'm not a dentist. I have no idea. Now, the interesting thing too is that Mary might have to wear glasses, but John, Debbie, and Mark can see fine without their glasses.
So none of the personalities know about each other.
Some of them do.
So some may know.
Like
Debbie might know what John
Mary
did.
might know about Debbie, and Debbie might know about John, but Mark doesn't know about anybody.
Okay.
So the brain controls it
So
all.
if I'm
The brain is controlling it all.
so some may remember what the others did, and then
Yeah, I mean, Mary might remember that Debbie tried to strangle her kid. Debbie might have tried to strangle her kid. Because sometimes you're going to have the really nice personalities, and then sometimes you're going to have the personalities that are really mean.
So could this happen in childbirth? Say they gave her an epidural and then she switched.
Could. It's a possibility. It's been known that one has diabetes and the other one doesn't. I know it's nuts and it sounds unbelievable,
So
but
you telling me?
that's what I'm telling you. I'm telling you
this.
this.
I'm a 65-year-old woman with renal failure, and then I'm gonna turn into Mark with healthy kidneys.
Could be.
What?
What?
But it's
I don't know if we've ever
psychological.
had anybody like that before, but we have had the diabetes thing. And we also have had the glasses thing.
So it's just psychological, but like lab work is still gonna be what it's gonna be, right?
I guess lab work is still going to be what it's going to be. So, I mean, if I did a DNA test on Mary and then I did a DNA test on John, it would be the same thing.
Right.
Right, okay. But not only is the personality changing, but also physical components of them can change as well. So you can see here on your PowerPoint, it says each of these identities may have a unique name, personal history, characteristics, including obvious differences in voice, gender, mannerisms, and even physical qualities as they need eyeglasses. They are also differences in how familiar each identity is with the other identities. Pretty wild, huh? I think so. Kind of think it's kind of cool. So this is how we assess a patient that we think might have a dissociative disorder. You know, are there blocks of time that you're unable to remember? Do you ever awaken not knowing your name? Do others think you're untruthful? Do you ever find unfamiliar objects at your home? I bet that Mary, who is the host, finds John's toys at her house and she doesn't know where they came from. But John is going to have toys, and when John, the 8-year-old boy, plays, he sits down on the floor and plays as a little boy. Have you ever discovered unfamiliar objects in your home and you don't know where they came from? Well, that's right, she probably doesn't. Do you have headaches? If so, how often and how intense are they? Sometimes they will change. That will be what is the factor that not causes them to change, but it lets them know they're about to change. How often do you have sleeping problems? It's another thing that we would want to know. Do you ever have nightmares? As a child, were you hurt or abused? So the bottom cause of all dissociative disorders is some type of trauma event, and many times it's going to be abuse of some kind. Your last dissociative disorder is depersonalization disorder. Well, I did have one patient that was, had dissociative identity, and I had her as a patient for 15 years. She had dissociative identity disorder. Depersonalization disorder is a feeling that the person tells you that they feel like they're on automatic. They feel like they're floating above their body and looking down at themselves. They feel that they see themselves walking down the hall. So it's an out-of-body experience or a disconnect from one's body. So it's a detachment from the environment and from reality. They don't hallucinate or have delusions, but they kind of lose touch with what's going on in the real world. So it's a feeling that everything around us here is not real, that it's all fake, not real at all. So they also have an inability to control emotions and also their life. So these are some of the things that a client with depersonalization would say. They would say, I feel like I'm in a dream world. I feel like I'm unreal. I'm not myself. I feel like I'm floating. My body doesn't feel real. When I was looking in the mirror, it was like the image was looking back at me. I feel like I'm walking through life like a zombie or a robot. Everything feels different, like I'm in a dream. And usually the feelings that they have are ego-dystonic. And the ego-dystonic feeling is a feeling that we have that goes against what our morals and acceptable behaviors would be. So it's unacceptable to the person's sense of their self. So the feelings are ego-dystonic. They don't know why they're feeling these horrible things. Okay, some diagnosis for dissociative disorders. Disturbed sensory perception, that would make sense. Disturbed thought process, memory loss, that would be one. Disorientation, loss of identity, so they can't recall the past. Ineffective role performance. Why? Tell me why they would have ineffective role performance.
If they feel like they're out of their bodies, then they don't feel like maybe they can do much, maybe.
What else?
They can't function in their day-to-day.
Identity. Well, yeah, they have multiple-
Right, when I'm married, if I go back and I look at this here, let me go back here and look at our people.
Oh, I guess
So when I'm-
personalities.
So when I'm married and I'm at work, of course I'm married. But when I'm Mark, I could be Mark for 4 months. So Mary's gonna lose her job because they're not gonna know where Mary is. And Mark is not gonna know why he's got women's clothes hanging in his closet.
I don't know, like, if they're changing into these characters or these different personalities, like, where is it? Is that just like a brief period where they're just, you know,
They've dissociated from the self.
as far as when they're changing, they just kind of,
You can sometimes see them change.
they're there when they're, I'm not confused, I'm just,
It's kind of weird.
You're in disbelief.
yeah,
Okay, there you go.
trying to see, like, is she married when she's changing the mark? Like, I mean, I know she doesn't.
Well, yeah, I mean, I've had a video that has a woman who is a clinical nurse practitioner, and she has DID, and she changes. And this is her real life story. And she's married, and so the husband knows she hasn't, and so when she changes, he just plays along with whoever she becomes.
So you just go along with it. You don't make them think nothing else different.
So Mark doesn't-
Nothing's going to help them but long-term psychotherapy.
So he called the job and tell the job that she can't come in, or she'll be there when she come back.
Mark just like, am I waking up in a dream?
Well, he might call the job and say, you know, Mary is,
Like,
It's John today.
Mark wakes up dressed like a woman and like, oh my goodness, like I need to go change or put my.
well, if he did, he would wonder why he's dressed like a woman. Or he might know about Debbie and knows he's been Debbie.
Okay.
He might know, he might know Debbie and know he's been Debbie, and he might not know them all.
Are all the alters, are they all aware of Mary, like the host, or
Are they all what?
do they all know, like, Mary?
They don't necessarily know Mary. And Mary doesn't necessarily know all of them.
Now you got us all interested. We don't even want to talk about this. Let's book this.
Pretty wild when you think about it.
Tell them about the trilogy. Tell them to watch the trilogy, Broken or Glass.
Okay.
Glass.
I haven't seen that. I've seen Split, but I haven't. Yeah.
I haven't seen that. Come on,
That's from the trilogy.
Split's on Netflix. There you go. So here's some nursing diagnosis: disturbed sensory perception, disturbed thought process, ineffective role performance. We talked about that. Ineffective coping. You're wandering from home. You're leaving home as an escape of perceived danger. So, and these are some of the outcomes we want. The client will engage with the therapist in a therapeutic alliance, or will engage with the nurse in a therapeutic alliance. We want them to get to the point where they can verbalize awareness of their alters, that they know about all these other people. We're going to teach them stress reduction techniques because stress is one thing that causes them to switch. We want them to report a decrease in negative feelings, maintain self-control, we want the patient to recover deficits in their memory. So if I'm John, Mary might, I might wake up then the next day and I'm Mary and I'm not going to know what I did yesterday because I was little John playing with my trucks and stuff.
Through treatment, can they know about the other personalities, or that's just something you can't control?
In treatment, you can, what you're going to try to do in treatment is to get out all the personalities and find out how many there are. Because you want, the thing that you want to have happen is you want the host to be the main person. You want all of the identities to convert back into the host and the host to be the person. You don't want one of the identities to be the one that takes over the control. Because that's not who the person really is.
Can that happen?
Huh?
Can that happen?
Can what help?
Can it happen that one of the others can take over?
Yes. Some of them want to take over. Some of them are mean and want to take over. Now, we can give them medicine for like certain symptoms, like if they're depressed or if they're anxious. But you have to remember, if they're switching personalities, they're not going to know who this medicine is for, and they're not going to take it because their name's not on the bottle. So I might show up as Debbie to get my medicine that my psychiatrist has prescribed for me. But when I switch over to Mary, Mary's not going to know why she has this medicine in her bathroom. Now, we do know that there is some possibility that antipsychotics will decrease the transitioning between personalities. So we do know that the antipsychotics do decrease the transitioning between personalities. But again, is the patient going to take it when their name isn't on the bottle? I don't know, maybe they put everybody's name on the bottle. I don't know. I don't know if they do that or not. Probably not. I don't think there's a pharmacist in town that would put 3 different people's names on a bottle. Questions about this group? And what's there to say, right? See, and you think a heart's interesting? Love dub, love dub. That's all it does all day long. And the brain is an amazing thing in what it can control. Some of the major goals for dissociative disorders, y'all can read over this, explore the client's feeling, assess for stressors. You know, are there any specific stressor that causes them to change personalities? So remember, with dissociative fugue, you become one personality. With dissociative identity disorder, you become two or more. Okay? Promote client safety, definitely client safety, because one of them, Mary, who is the host, knows she's doing something crazy and she might try to commit suicide, so she doesn't have to go through this. She might try to kill herself. We're going to try to give the identities coping mechanisms. We're going to give them positive feedback for each time that they change back into the host. So you're back, Mary, you're back to your original person now. I'm so glad that you are. And sometimes, depending on the relationship that they have with their psychiatrist, they can the psychiatrist can get them to actually change when he asks them to. So they'll change per request. He'll say, I'd like to speak to John right now. Now, the interesting thing is that John might not know about Debbie, but Debbie would know about John. Well, you wouldn't. I'm just saying that's sometimes a scenario.
I watched an episode of Dr. Bill, who was interviewing those people, and he asked to speak to them.
And the other one came out?
Different person, different voice, different demeanor.
Different everything. Yeah. Definitely. Yeah, it's pretty wild. Okay, our next group of disorders are called somatoform disorders. Now, the word, if we just take the word somatization by itself as to what it means, it is not, that word somatization is not a mental illness. Somatization is something we all do. In other words, if I'm upset and stressed, I might get a headache. If I'm upset and stressed, I might get a stomach ache. So it's the way the stressor is directed through the body. It comes out in a headache. It comes out in a stomach ache. It comes out as diarrhea. Okay? So that's basically what somatization is, and all of us do that. And maybe you've gone through a really stressful day and you go home with just a terrible migraine. Okay, that's somatization. So the body has to have an outlet for stress, and so that outlet is called somatization. Now, when it goes beyond just normal somatization, we have somatoform disorders. Somatoform disorders are physical symptoms that the patient has with no organic cause. The cause is psychological, and they are not faking. So physical symptoms, no organic cause, they are not faking. These patients are usually pretty poor historians. they're bad at giving you, they're not very good at giving you a history. What causes somatoform disorders? Neurotransmission changes, genetics, environment. Specifically, environment where the person was raised in a chaotic family. So the first one under somatoform disorder is called conversion disorder. And it's somehow a deficit in sensory or motor functioning that's not intentionally produced. So you have to remember here, they're not faking, because we'll talk about those patients that fake. So these are patients who are not faking. So again, deficits in sensory and motor functioning. Go ahead.
You said the causes of neurotransmission, environment, and what else?
Genetics in a chaotic family. So conversion disorder is when there's something going on in their sensory, in their senses, or their motor ability. So it's not intentionally produced. It is the loss of their functioning is due to psychological conflict that they don't know is causing them conflict. So the primary gain here, and gain, I don't want you to think of that as this is something that is voluntary. It's just what psychiatry calls it. Primary gain is to keep whatever that conflict is out of conscious awareness. That's the primary gain. To keep the conflict out of conscious awareness. So maybe an example of this might be a woman's been sexually assaulted and the police call her up and they say, we'd like for you to come down to the police station and see a lineup and see if you can pick out your perpetrator. And she says, okay, I'll be there in the morning. But she wakes up and she's blind. So she cannot see. She's gone blind. So the primary gain is she doesn't have to worry about recognizing her assailant because she can't see. Does she know that that's what's going on? Absolutely not. She cannot figure out why she can't see. Maybe it's a person that's been deployed or is going to be deployed, and he's consciously not aware of the fact that he doesn't want to go to Iraq, okay? So maybe he doesn't really know that. He just knows he's been deployed. And so he goes to bed and he wakes up the next day and he's paralyzed and can't walk. There's nothing physically wrong with him. It is just, it's caused by psychological reasons. So it's just how the brain can take control over the body.
Does that last forever?
No, they can come out of it.
That's like protecting the body.
So the brain is protecting them. So the primary gain is to keep conflict out of conscious awareness. The secondary gain is either to avoid something bad, which would be deployment, or receive support, or receive some type of support. Now, the thing about conversion disorder that's specific to it is that these patients experience something called labella indifference. They don't seem to be really that upset that they've gone blind or they can't walk. And that's something that usually clues us in that it's conversion. Another way conversion disorder can manifest itself is through false seizures. So the patient is having grand mal seizures, but when we do an EEG, their brain does not show that. So again, the primary gain is to keep some type of conflict out of their conscious awareness. And the secondary gain is they either avoid something bad or receive support. So maybe what they're getting from it is actually attention. Are they consciously aware that that's what's going on? No. Are they purposely doing this? No. Okay?
What kind of seizures?
Grand mal. I had a student with a conversion disorder. Every time I took her to clinical, she had a grand mal seizure at the drug cart. We'd call the EMTs. So she went to the hospital, and they did all this workup on her, and they couldn't find anything. And so the doctors in the doctors in the intensive care where they had put her, told her that. So she asked them, she said, so I asked her, I said, well, what did they recommend for you? I knew what she was going to say, but she said, well, they told me I needed a therapist. And that's exactly what she needed. Because those seizures weren't real. She wasn't faking them. You can't, her blood sugar dropped, and we had to give her a glucagon shot. It was that low. It was like in the 40s, it had dropped. And she had had a grand mal seizure. You can't fake crap like that, okay? You know what I'm saying? I can't fake a 40 blood sugar. Now the next one is really, I think, a sad one. It's called hypochondriasis. Sometimes you might hear it called hypochondria, and we use this term inappropriately because this is where we think the person is just faking and making up one medical problem after another. Hypochondria is an overwhelming fear that I have some type of horrible, serious disease. Remember that all your somatoform disorders are unconscious. Okay, where's the unconscious on the iceberg, according to Freud? Way in the bottom. Do we know what's going on down there? Mm-hmm. So that's where all this takes place. So they believe they have some type of serious illness. So they're consumed with fear. So they might do something called doctor shopping. Now I'll give you a real life story of a man I worked with. He believed, I didn't know that this was what was going on, but I knew something was wrong with him, and I couldn't quite figure out what it was, because I was watching. I hate to admit it, but I kind of followed and watched him. So I was working someplace else because I knew something was wrong. Okay. And so, like he'd be on the phone and he'd be out at his car on the phone. I thought, well, is he having an affair? Something's going on here. And so what we found out is, well, first of all, how we found it out that it was hypochondriasis is he killed himself. Okay, so what happened was he was doctor shopping because he thought he had multiple sclerosis. And so what they do is they take a normal body sensation and in their head, they make it something that it's not. So he was having some leg pain and he thought it was MS. So he would go to the doctor, and the doctor would say, well, I've run tests, you don't have MS. Yeah, I do, I know I've got it. I can't live like this. I can't leave my family having to take care of me. He was married with 2 young children. And so what they do is they misinterpret normal body functioning as something horrible. So they misinterpret normal body functioning as something horrible. They're not faking, they're not making it up. And the doctors cannot reassure them. So that's why they go from doctor to doctor. And when they go to the doctor and they see the doctor, and the doctor says, I've run all these tests and nothing's wrong, they're furious about it. But they said, it's got to be something wrong with me. Questions about that one?
Can they have this, disorder and maybe do it towards other people? Like,
We're going to talk about that in a minute.
next.
Pain disorder, this is where they're having horrible pain, but we can't find a cause. Is the pain real? Yes, it is. Are they faking? No, they're not. So these are your somatoform disorders: conversion, hypochondriasis, pain disorder. Now let's talk about the people that are faking. And these are malingerers. They are deliberately faking for some kind of benefit. So they're either trying to gain something good or avoid something negative. So they are motivated with a secondary gain. So this would be the person that has gone out and murdered his wife, and he's faking mental illness so he can get the not guilty by reason of insanity plea. This is not a psychiatric disorder, but it's something that we talk about in psychiatry because this is where we see it come up from. I mean, this is where it's talked about in the medical field. So it's not a psychiatric disorder. So the secondary gain could be attention. The secondary gain could be financial, slip and fall person. You know what I'm talking about? You know, they slip and fall everywhere, doing it on purpose so they can get them an attorney and call Alexander Shannara, you know, and get them an attorney. So they're going to gain something positive, attention or financial, or avoid something negative. So if I've just gone in and I've shot a school up, I'm going to fake mental illness, try to fake it, so I can serve time in a mental hospital as a not guilty by reason of insanity and not have to go to prison. But what we're going to do, because we're going to be one step ahead of them, is we're going to give them the MMPI. Because remember, the MMPI has a line scale on it. And we're going to know if this person is malingering, because it's going to show that they're lying. And they're going to get a forensic evaluation by a psychiatrist. So, for example, someone might pretend to be injured so they can collect an insurance settlement or obtain prescription medications. Others may exaggerate mental health symptoms to avoid criminal conviction. Okay? More specific examples of malingering include putting makeup on your face to create the look of a black eye. These are people in psychiatry that we don't like because they're trying to fake something that isn't true. They're trying to get away with something bad. So we want to separate them from those people who are truly mentally ill. Factitious disorder, also known as Munchausen disorder, is, first of all, let's talk a little bit about what just factitious disorder is. There's two types of factitious. There's either factitious, or I'm doing it to myself. And Kendra, this is something you're talking about. Or it's factitious disorder by proxy, where I do it to someone else. So factitious is basically they're lying. Okay? They have purposely thrown themselves down the steps to break their legs and arms for the attention that they are going to get when they go to the doctor or if they go to the emergency room. So they have fabricated their sickness because they enjoy the sick role. What causes people to develop factitious? So remember, they're lying. They're not going to tell you they purposely threw themselves down the steps. They're going to say, I fell down the steps. Oh, you poor thing. You know, and that's what they want. The cause of this is emotional conflict like childhood abuse or childhood neglect. So this is conscious symptom production in oneself or to another. If I consciously hurt another, or if I constantly make another sick, it's factitious by proxy, where I'm making this other person sick so I can get attention from the fact that my child is sick. But why is my child sick? Because I'm purposely making him sick.
You watched that Lifetime movie about that?
No, I didn't. Did you?
Her mama was
Making her
injecting
sick?
her with like some type of medication and putting her in a wheelchair. She wouldn't let her go outside. I can't remember the name of the movie.
Gypsy. Yeah, I remember people talking about that. Yeah. Factitious by proxy is when I purposely make another person sick. Factitious is when I do it to myself. So by proxy means to another. So
Okay.
So let's look at this, just for example. Okay, so factitious and malingering. Major difference from malingering is that an individual with factitious disorder has a physiological need, to assume the sick role. Assuming the sick role is their only gain. They just want to be sick and taken care of. Factitious disorder is a condition in which a person without malingering motives acts as if they have an illness by deliberately producing it, feigning it, or exaggerating symptoms purely to attain a patient's role, which is to be sick. They enjoy being sick, or they enjoy the attention they get when they make another person sick. Okay? Both malingering and factitious disorders are voluntary and they're consciously produced. So the conscious mind is doing this. They are lying to you. Okay, so they are lying to you. So again, I've got just, it went under factitious disorder, also known as Munchausen disorder, or factitious disorder by proxy. So they'll be willing to undergo painful or risky tests and operations in order to get the sympathy. They want the attention. They want people to think they're truly ill. Factitious by proxy also is considered a mental illness, and it's a form of child abuse because they're generally doing it to their child. Now, there are nurses that do it to their patients. Yes, they do, where they get the patient to the point of coding, and then they run in and they save the patient, and now they're the hero. So we do see it in the medical profession. I've just ruined your life for you now, haven't I? Okay, so make sure that you know the difference between these. So let's look at the symptoms of each one of them. Malingering. Malingering is conscious. The gain is external, and it's deliberate. They're deliberately lying. Factitious disorder or Munchausen disorder, which is also called, is conscious. What's the gain from this? The sick role. They love the sick role. Is it deliberate? Yes, it is. Is it a psychiatric disorder? Yes, it is. Will they agree to procedures? Yes, they will. Will malingerers agree to procedures? No. So that's one way that we can figure out if someone who's done some kind of heinous crime is a malingerer, because they won't do any type of procedures or tests. Somatization or somatoform disorder that we just talked about. It's unconscious. There is no gain with the conversion and hypochondriasis. There's no gain. It's not deliberate. It is a psychiatric disorder, and they will agree to procedures. So it's really important that you know the differences. Just a minute. I got my papers on this stuff, but give me a second. For malingering, if you have a patient that is a malingerer, there is no treatment for them. So there's no treatment for malingering. For the other ones that we talked about, the factitious the factitious, and then the factitious by proxy, of course, is therapy. I mean, medicines really aren't going to help these people.
For somatization too?
For somatization, well, if I have a headache, I take aspirin.
So they don't do therapy?
I might do some therapy to help them learn how to control their stress. Other questions about this group? Okay, so we're going to move on to chapter 20. Well, I'm sorry. These are some examples that we have identified that parents or caregivers do who have got a factitious disorder by proxy. Put blood in the child's urine, withhold food so the child looks like they can't gain weight, give them drugs, infect an intravenous line to make the child sick, water signs in the mother. Some are adult children taking care of an older parent. So it could be that, or it can be a younger mother taking care of a small child. They often work in health care, and they know a lot about medical care. So there you go. We see this, unfortunately, in nurses. She can describe the child's symptoms in great medical detail. She's going to be over involved in their health care. They're very involved with their children. They seem like the devoted mother, but what they really are is a child abuser. Outcome for somatoform disorders: ability to cope with their anxiety. Try to figure out what the source of anxiety is. Why do you think you suddenly can't walk? What do you think's going on? Express feelings instead of producing it symbolically through physical symptoms. Let's talk about how you feel. So I want to talk about how they feel. I don't want them to tell me about how sick they are, or that they can't walk, or that they can't hear, or they can't see. I want to talk to them about how they feel, because you see, it's something that they're feeling as a result of something in their life which is leading to the problem. The client is able to identify the relationship between stress and the physical symptom. And then they can identify alternative ways to deal with their stress, their anxiety, and other feelings. A key to working with these disorders is trust. Encourage them to express their feelings instead of symbolically producing symptoms. Again, we want them to talk about how they feel. Try and increase their comfort with the physical illness. Don't rush into judgment with somatoform disorders. Remember, don't forget they could really be sick. So we have to rule out that they're not really sick. Okay, we got to rule that out. So remember, somatoform disorders are a maladaptive response to stress. Nursing diagnosis: ineffective role performance, ineffective coping, disturbed thought process in sensory perception. They distort reality, they have impaired judgment, they filter out anxiety in response to anxiety. Okay, so that would be some of the reasons why you would give those diagnoses for them. Let's take about a 10-minute break. And we'll come back and talk about Kate and all her friends.
What's it again? Then you don't need it. You gotta make sure somebody.
Do you know how many days a week is gonna be to January?
You know, if it's 160 weeks, that's 4 months, that's the regular.
I know, but I'm saying that we did 8 weeks, 2 days a week.
They're gonna have to take tests every 2 weeks. Exams will be every 2 weeks.
That means the lecture might be shorter.
Exactly, everything will be stretched more out. It's no longer a fast paced school, you know.
I know,
It's a normal.
cause I got a horrible pass rate. It's a 31%.
Oh,
Not in clinic, people passing, Herzing is a 31% pass rate. That's why they changed
That's bad.
it, cause they got a bad one.
They do. I see that coming from my little house. Yeah. That's how, that's because at the end, they
Is
do.
that later to it is?
Right.
What's the plan for the implants? The majority.
Every 2 weeks for exam.
Once it's fresh on you. Next time you tell you everything, I will do it.
You wish you did what?
Yes, measure to regularly.
Yeah, that's what I'm thinking. Oh, but med surg too, gonna put
Everything.
everything in.
Everything
She
you
pulled
want
from
from
mental health.
pharmacy to peds. It's gonna be on our.
We're not gonna have to get done here. We'll say, well, if you like to shoot me here, I can put it on the thing. Nobody put it in. Well, I don't know.
I can't imagine being elected for 8 hours.
We did
This
our break.
is
Girl,
8 hours and 1 hour break. Wow.
That's how it was,
To work.
with,
8 to 5 p.m.
You want the LPN food? You want the LPN food? How you took that place? Oh, but you're not bringing you straight through. Okay.
Oh,
You straight. Are you ready to go? You are? Okay.
is it too late?
I feel you right there.
Well, you work with me, baby, too.
No,
We
that's
ain't
it.
too long. I ain't put up to nothing. Ain't got no bachelor's, no master's. Don't talk to me. She said, don't talk to me. They'll even pay me. No more.
When we agree,
Depending on where you look at. And maybe all these
Yeah.
So, I don't like one of those subjects.
Exactly.
So I must say,
Look, you get it back.
I'm good with
Yeah.
it.
That's it. Time for one
where
day.
you put the,
Me too.
put it which you are. That's what so, and this one is,
I wanna wait.
that's what
I
scheduled
wanna wait this month.
for, so, so I put yeah, instead of it does all of that.
But that's the master's gonna always.
Yes,
Yeah, I need
how
management.
I leave that to you to evaluate.
I'm trying to manage.
Yeah, it's when you wanna change your condition,
Yeah.
that's when you need to. But see, look, it's already up there, you can change however much you want, you can go from houses, bills, some people work on how many things, so they just do like HR.
Now, when I get married and live my self life, I work at home.
Or tell cars, tell videos and.
Right there with my baby on my hip.
Yeah, one lady, one girl, she told me she just helped people buy insurance. I can do that.
They never do it.
Yeah, she just been used to the,
You don't have to be her. That's it, she works from home.
I'm gonna have to find it out there, but I'm
Yeah,
doing
I do
everything
that. All
else
she
right
does
now.
I was gonna say, she's somebody right out.
Yeah.
I will do that all day.
I ain't trying to work
Yeah.
out for real.
Great.
Oh, maybe I'm gonna shift that, you know, what type of thing. She's not gonna start.
I mean, that's real talk, I don't like nobody. Yeah, I don't think.
They know.
Right.
You want everything,
Maybe if you.
Like, no.
If you don't get it, it's totally the floor, that's not a fault. So she gonna do your urine.
They gonna get you that double one, I promise. I just went out there before, I'm like, I ain't that good. Why you ain't getting this? I ain't that good.
Okay, so let's talk about gender identity and sexual disorders. The sexual disorders that we talk about in here, the paraphilias and everything, these are all Axis 1 diagnoses. Okay. So a sex assigned at birth, this could be male, female, or intersex. So what intersex is that we're not really sure what the child's sex is because they have both male and female sex organs. So we have to do genetic testing to determine that. However, the sex, we know now that the child is assigned at birth, whether it's male or female, does not determine their gender identity. Okay, so it does not determine what their gender identity is. So if we were to define gender identity, it is defined as your own private sense of if you see yourself as male or if you see yourself as female. So gender identity is really kind of on a continuum. We can say that gender identity is congruent with the anatomic sex. So my anatomic sex says I'm female, and I know I'm female. People who have both male and female gender identities is also another option. And when the gender identity conflicts with their gender that they were assigned at birth. So that would be, I was born a female, but I feel like I've always been a man. Okay? So you don't have to know these for your test, but you've probably seen these written or heard these words. Agender, I mean, there's bunches of different words: agender, bigender, gender fluid, gender queer. MX is a title that is gender neutral. Third gender, they don't see themselves as a man or a woman, but identifies with another gender. Okay, so let's talk about some definitions here so we can understand them a little better. In psychology, there is a word called androgyny. And androgyny is a good thing for you to be, because you're flexible regarding gender stereotypic behaviors. So you're a woman that can mow a yard if you need to, and trim up your plants, change a light bulb, work on your car. You can also be feminine if you need to be. So you can do a man's task, general task, what has been defined as their general task. And if you're a man, you can do what sometimes is considered the woman's job. Do the clothes, take care of the kids, change the diapers, go grocery shopping. Okay, so that's what androgyny is. So you're flexible, and that's a good thing to be. Now, transsexual is when the person actually has their sexual organs changed. And they do that through going through surgery. So they have in their mind a sexual incongruence. So they have a discomfort in general with their assigned gender. So their sexual anatomy is not consistent with their gender identity. So these individuals have and begin to experience what we call gender identity disorder. Now make sure you understand these. Gender, first of all, gender, let's skip down and talk about what gender identity disorder is. It's also called gender dysphoria, and it is an Axis 1 psychiatric disorder. So this is when a person is born male, but they've got male sexual parts, but they've always thought of themselves as a girl. So as they grow older, then they begin to start taking on female characteristics. They are now considered transgender. They're transgendering. They're transitioning to a different gender. They identify and experience a gender, the feelings of a gender, different from the one that they were given at birth. So they have a non-conforming gender identity. They're trying, so they begin then, a transgender person is someone that starts dressing and acting like the gender they want to be. I went out to eat with a friend a couple of weeks back, and the man that waited on us was transgender. And I just think these people are cool. I really like transgender people. So, he was definitely, he was a male, but he had his fingernails done, looked real good. Hair looked better than mine did. He had his makeup on. So he was in the process of transitioning to that female gender. So that's what transgender is. He was beginning to make that that transition. Now, when they actually make the full transition and get the surgery where they have their sexual organs changed, that is when they are considered a transsexual. So they have sexual discomfort with their actual organs, and they actually have to have those removed. They have to either have their penis removed or made into a vagina, or they're going to have a penis somehow, penile prosthesis implant somehow put into their body in a certain way. I don't know the details of all that. So as a nurse, these are going to be people that you take care of. And you have to build a relationship with them. So you have to be self-aware enough to know if you think you've got issues with this type of patient, because it could affect your ability to care for them. See, I like these kind of patients. See, you give them to me, I'll take them, I like these kind of patients. I know I told the guy that was waiting on our table that I told him, I said, I just love your fingernail polish. He said, well, thank you. He said, I had my nails done the other day. I said, you did? I said, I need to start having my nails done. So we just had a big discussion. He told me the color of it and everything. So, I just think that transgender people are just, I had them in my practice and I really like working with them. So gender identity disorder is now called gender dysphoria, and it is an Axis 1 diagnosis. It's a psychiatric illness. So the patient believes they were born the wrong gender. So there is a dysphoria there. There's a confusion in their mind between the gender that they physically have and the one they know themselves to be. Now, sometimes just because someone's transgender doesn't mean they're going to get their sexual parts changed and become transsexual. Sometimes they don't go all the way and do that. It just depends. Questions about these so far?
So you said gender identity disorder is a psychiatric disorder?
Yeah, it's Axis 1.
So there's treatment, is there a way to?
Generally, there's no treatment. I mean, if I believe I'm male, I'm going to change to being male. If I believe I'm female and I'm a male, I'm going to do that. What we do, or what our goal as a nurse is to do, is to accept them for who they are, establish a relationship with them, and help them transition to the world we're going to be living in and to cope there. So by accepting them as a nurse and treating them with dignity and kindness, we are accepting them, and that is a form of being therapeutic. If you ever take care of a patient and you don't know what gender they are, you always ask them what they prefer to be called. So don't call Mr. Jones if he's really Miss Jones. So you ask them, what would you prefer me to call you? What gender do you identify with? They'll appreciate that.
I struggle with that transgender, and I would call him girl all the time, or I tell my kids that that's they auntie.
Their auntie instead of their auntie.
Their auntie.
Their auntie.
All of these are gender identity disorders, transsexual, everything, all the.
Transgender is just another name for GID. So gender identity disorder is dysphoria. You're not happy with the sex in which you were born. So, and this begins as early as the age of 5 years old. We can begin to start seeing that this behavior is there. And the child is going to fight this to the bitter end to get their gender changed. Did your brother?
He used to paint his toenails and everything. I swear it started earlier than that, probably when he was like 3 or 4. We could
Yeah.
always tell that he was wanted to be a girl growing up.
Yeah,
Always.
right. So has he become a transsexual?
No.
Okay.
He still has his parts or whatever, and he still has a beard, and he's weird. He got a beard and then will wear a wig. Like, I don't understand. It's so crazy.
Okay. Well, you know, we have to be who we are.
The beard off.
Yeah, well, maybe you can help him with a little bit of his grooming kind of thing.
Transsexual is not under EID.
No, transsexual is different. Transsexual is when I've actually had my sexual organs redone.
So Dwayne Wade's son would be considered.
I don't know who Dwayne Wade is. I don't know who these people are.
Oh my God.
You don't watch TV?
Not much. No, I read. So what were you going to say about this person?
Well, his son identifies as a girl, dresses like a girl, has a new name. I think he's like 12 or 13. He started younger than that.
Uh-huh.
And I guess they're he wants to like do the sex thing, the sex change, all of that. Now it's so young.
Yeah, that's awfully young. That's, you know, and that's one thing that parents need to consider is that before they allow their child at the age of 12 years old to make a sex change, they need to go to a therapist who specializes in this kind of thing and do therapy before they ever allow that to happen.
This gender stuff with my brother, it kind of led him to depression where he was actually, he tried to kill himself when he was in kindergarten, actually. He tried to cut himself with scissors while he was in school, so he had to go to a psychiatric hospital because of the depression behind it.
Because he felt he was wrong, he was the wrong gender?
Our mother, my mom didn't raise me, but our mother basically, told him he couldn't do it and, whatever they do when they're against you being what you're not supposed to be, or what they think you're not supposed to be.
Right.
It led him to depression. And he still suffers through depression a lot because of it.
Oh, I'm sure he does. I guess these people kind of, they feel lost. It's a rough life because they're trying to find their identity. So gender identity disorder and gender dysphoria is really the same thing, and it's an axis 1. And a transgender is just another name for GID. That's the one that you see used most often. Now, let's talk a little bit about what a cross-dresser is. A cross-dresser, we don't call them cross-dressers anymore. These are usually men that are male. They're married. They have children. Cross-dresser, the DSM-5 and the American Psychiatric Association now calls it transvestite disorder, and it is a DSM-5 diagnosis, and it's axis 1. So it is transvestite disorder. Previously, these were called transvestites. Okay, but now it is transvestite disorder. So they're not homosexual. They're heterosexual. They're not transgender. They have transvestite disorder in that they get pleasure out of dressing in women's clothing. They're married. They're straight. They got kids. They just want to express their feminine side. This chapter always upsets everybody. This is one of my favorite chapters. I love working with these people. They're fun. Okay, so that's what a cross-dresser is. So again, it's now called transvestite disorder by the DSM-5. And it is considered under the major heading category now, a paraphilia. And we're going to talk about the paraphilias a little later. So most of these men have masculine identities. This dressing in women's clothing may occur at home. It may occur out in public. It doesn't mean that they want their sex organs changed. It doesn't mean they want their gender changed. They just like to dress in women's clothing. And they like to sometimes receive sexual pleasure from the clothing that they wear of a female. So they experience sexual pleasure from wearing the female clothing. Correct. Now called transvestic disorder. So these people who are transvestites or have transvestic disorder are comfortable with their gender. They are not transgender. But they occasionally dress and take on the mannerisms of the opposite sex. But it does not mean that they're transgender. They just like to express their feminine side, or they are getting sexual gratification from the clothing that they're wearing. Like I said, they're generally married, they're heterosexual, and they have children. Drag performers, I just put this in here because sometimes everybody thinks that a drag performer is gay. That's not necessarily true. Sometimes drag is just their job because it pays good money and they're straight. So it doesn't necessarily mean that the person's gay. It could be that what they are is a performer and nothing else, that they're happy with their gender, they're happy with the sex that God gave them, but they just do this for a living. Some are gay, some are not. They're not necessarily transgender. And drag performers aren't necessarily members of the transgender community. Like I said, they could just be doing it because this is what they do for a living and it pays good money. Remember, transgender, a good way to remember this is that the word transgender is one's identity, not a performance. So never assume that drag performers are transgender or vice versa. Can transgender people, they can be gay, straight, or bisexual.
What's the difference between cross-dressing and drag performance? I mean, like, aside from their performance,
Well, the people that are your cross-dressers aren't performing. They're just doing it because they like dressing up in women's clothing. They're not doing any kind of performance for it.
so even in drag, they sometimes might not have the pleasure from clothing, like you said, they just get paid for it.
That's right. That could be a drag performer. That does not mean that they're gay. It could be a straight man that's doing this because he gets paid good money to dress up like a woman. Okay? So we can't assume is what I'm trying to say. You don't automatically assume somebody's something when they're not. Okay? You don't automatically assume it.
Ms. Lavas,
Yes, ma'am.
back to the children that come and know, at 5 years old, that they want to make that, transition or whatever. Are there any signs prior to that, or
Are they what?
is there any signs prior to that, or is it anything that would?
Yeah, the signs are that they are attracted to their opposite gender activities and things. So the little boy is going to be attracted to girl stuff. And the little girl is going to be attracted to boy stuff.
So is it something that the parents can do, like if they notice that, like the child?
They can try to navigate them toward the gender that they were born, but it's not usually going to help. They're going to fight it.
Your biggest issue with these type of children is when you're dealing with certain religions.
Yeah,
They're not gonna accept it.
right. They're not going to accept it. But, and that's really sad because, if you can't, if you can't depend on your family, who can you depend on? You know?
You usually get new families. Like they might have a older gay guy that he calls his father. Like they have their own community.
Yeah, that's one reason they do have their own community, because they understand each other. Yeah. So this is a genderbread person. And this is just an example of, you don't really have to know it for your test, but your gender identity occurs in your brain. So if you think you're male or if you think you're female, that's your brain telling you that. Okay? Your orientation or your sexual orientation is who you are attracted to. Are you attracted to the same gender you are, or to the opposite gender, or to both genders? And then, of course, your biological sex. Are you female, male, or intersex? Meaning that you have been born with more than one type of sexual part, so we're really not sure if you're male or female, so we're going to have to do some genetic studies to find out exactly what gender you are. So sexual orientation, when we think about sexual orientation, am I heterosexual, where I'm attracted to the opposite sex? Am I bisexual, where I'm attracted to both sexes? Or am I homosexual, where I'm attracted to the same sex? So that's what orientation is. See what you're learning in here? Look at all this neat stuff you're learning about. So, gender dysphoria may impact a person's choice of their sexual partners and their self-concept. Identity, a person's conflict with their identity needs to be something that they have been fighting over a period of time for us to realize that they have gender dysphoria. So it's not just something that, hey, one day you wake up and you want to be a girl, okay? It's something that has been going on for a long time. People who are born with an ambiguous genitalia, or we're really not sure if the genitalia is male or female, they can raise questions about their own gender. They may develop gender dysphoria because they don't know what gender they are. The actual cause of this is unknown, but hormones in the womb play something to do with this. Genes and social and environmental factors as well, such as parenting, we think may be involved in some of this as well. So, how we might know that a child has gender identity disorder, which again is Axis 1. Symptoms can vary by age. Children may be disgusted with their genitals, be rejected by their peers and feel alone, believe they will grow up and become the opposite sex, say they want to be the opposite sex. As they become an adult, then they have more of a freedom to dress as the opposite sex. They also might feel very alone, which is what we don't want them to be. If they're transgender, we want them to be in the transgender world. Okay, we don't want them to feel like they're isolated out there with no one that they can relate to. So we want them to learn to live as that person. And generally, not generally, but some people who are transgender don't want to get rid of their genitals and have the sex change operation. And then some do want the sex change operation. And I think Kate or Jenner, who he was before he came out as a transgender patient, a transgender person, has already had the sex change. So he's already a transsexual. Okay. I had a patient one time, it was a male that came to see me, and he came to see me because he had been dating a woman who was a transsexual and he didn't even know it. And he was having sex with her and he was clueless. He had no idea that this person that he was having sex with was female. So they can create a vagina that's actually fools the guy.
Would it be legal? Like, what if he was a straight man and
Well, he was a straight man.
that's how people get killed?
Well, yeah, they get killed that way. That's why he came to therapy with me, because he was so upset because he started thinking that he was gay. And I said, no, you're not gay. You're not. You're heterosexual. You thought this was a woman. He said, she looks just like a woman and she has a vagina just like a woman. I said, that's right, because she's changed into a woman, but that doesn't make you gay. So he was just really, you could see where that would mess somebody up. You know what I'm saying? He was really messed up by that. But he got better with it and he moved on, so. So you just don't know who you're going out with sometime, you know what I'm saying? He said she was beautiful. I said, well, I believe you. I said, I know. I've seen some transgender men that look a whole lot better than I do. You know what I'm saying? They look a whole lot better than I do, and their hair always looks better than mine. Okay, so let's talk about paraphilias. So transvestic disorder is now under paraphilias. Paraphilia is an axis 1. It is usually sexual arousal that occurs with an environmental stimulus. So it can be, paraphilias can be sexual arousal toward objects, sexual arousal toward children, situations, certain behaviors. It's generally going to be the male population who have paraphilias, and they can't stop doing what they're doing. They're very obsessive and compulsive about it. So they can't stop their behavior. So they're really considered unconventional sexual behaviors. Now, paraphilias, there it is. So what we know about paraphilias is there seems to be an imbalance in dopamine, norepinephrine, and serotonin. And you've got to remember that these are your feel-good chemicals. So imbalance of these chemicals can lead to compulsive sexual behaviors, sex hormone dysfunction, and changes in brain connection. Now, when it comes to paraphilias, there's a difference between coercive and non-coercive. A coercive paraphilia is when you do a sexual act toward a person who doesn't want it, or you do it with an animal. That's non-coercive. That's coercive. So these are considered criminal acts. So they're going to attack or do something to non-consenting people or animals for sexual arousal. Non-coercive is when you do unusual sexual acts with a consenting adult. So people that have paraphilias generally are going to associate sexual arousal with an environmental stimulus. So let's look at your first one, exhibitionism. This is flashing. So this is where you flash your genitals at somebody, to an unsuspecting person. So you can see that it is coercive. The other person is not wanting this. They're not desiring this, but it is done to them anyway. So the person is in shock. They are a victim. An actual sexual contact is with the person that they're flashing is rare. They just get sexual arousal while exposing themselves. They get sexual arousal when they expose themselves to other people. Has anybody in here ever been flashed? I have. I've been flashed before. And so, of course, I look at him and I say, well, you have exhibitionism. And I said to him, he's going to look at me like, oh. So you have exhibitionism. It's also known as flashing and a coercive paraphilia. And he just left. So he thought, well, she's no fun. I told him, I said, I've seen plenty of naked men. I said, it doesn't do a thing for me. I'm a nurse. Hello. Okay, fetishism. These are people that have sexual urges associated with a non-living object. Shoes, underwear, things like that. They become sexually aroused by wearing it or touching it. The object of a fetish could be underwear, like I said, rubber clothing, shoes, lingerie. The thing about the fetish is that the actual thing they have the sexual arousal for, the inanimate object, can replace normal sexual behavior. So it can become more important than normal sexual acts. Frauderism. This is where they get sexual gratification by fondling you or touching you or rubbing up against you, their genitals. Most frauderists are males, and they do it against women. And it's usually in a crowded place where you get your butt, but you're in a crowded place and somebody grabs your rear end. That's a frauderist. This contact is illegal. So it is a coercive paraphilia. It's being done against someone's will. Pedophilia, people with fantasies or urges for wanting to do illegal sex acts with children. Yes, sad to say, but it is an Axis 1 psychiatric disorder. Children are generally 13 years and younger. Sexual masochism and sexual sadism. These two people generally hook up. Okay, so individuals with sexual masochism enjoy being humiliated or beaten or made to suffer during sexual act, where the sexual sadist is the one that enjoys inflicting the harm or the pain on the person. So you can see how they hook up with each other. One's a sadist, one's a masochist. Some sexual sadists are also psychopaths, where they what was I gonna say? I forgot what I was gonna say. Where they, before they kill the person, they sexually assault them and harm them physically before they kill them. So make them suffer. So they're sexual sadists. That's what Jeffrey Dahmer was. He was a psychopath. He was also a sexual sadist. I've had patients who are peeping Toms. They were court ordered to my counseling practice. And this is where you want to peek in people's windows or videotape the girl's bathroom, and you get sexual arousal by watching non-consenting people who don't have any clothes on. The voyeur does not seek contact with the person. He or she is just wanting to observe them. So another name for them, as we've all known, is called the peeping Tom. This could be the guy or the man, because these are generally, paraphilias are generally male psychiatric disorders. So this could be where the man sets up the video camera in the girl's dressing room. That would be an example. How many people have heard of autoerotic asphyxia or hypoxophilia, also called head rushing or scarfing? Yeah. So it's now under sexual masochism disorder it's now called sexual masochism disorder with asphyxiophilia. So basically what it is the patient is got a rope and they're hanging it around their neck. They're probably going to tie it to a doorknob because they don't want to die. And they're masturbating while they choke themselves. And that when they reach to a certain point of choking themselves, it gives the sexual event a rush. So sometimes these people end up accidentally killing themselves because they don't undo the noose soon enough, so they die. This is when you just do it on your own, right? Remember, I don't know if y'all are too young to remember, but do you remember the program Kung Fu? Okay, David Carradine, he died that way. The actor David Carradine died that way somewhere in China. He was in an apartment and they found him doing autoerotic asphyxia. Erotic asphyxiation is also breath control, and this is when you have, it's called asphyxophilia, erotic asphyxia, or hypoxophilia. Basically, this is where you are choking somebody during the actual act of sex, which makes for a higher sexual experience. And so sometimes what happens is the patient chokes them too much. I mean, the individual chokes them too much and they accidentally kill them. So you're sitting there saying to yourself, what do we do with them, Miss Lavas? Well, we do psychotherapy. They do go to therapy. They are mandated to therapy. We might give them antidepressants or anti-androgens, which inhibit sex hormones. We could give them mood stabilizers like Depakote and lithium. Naltrexone. It also helps block the pleasure receptors, remember, in alcoholism. So it also helps block the pleasure receptors in the sexual act. Sexual desire disorders. I've had patients with these before. This is, these are considered psychiatric disorders. And the first one we're going to talk about is dyspareunia. And this can be either seen in males or females, and it's pain with sexual intercourse. There's nothing wrong with the patient anatomically. This is all psychological. It could be due to a partner who is not understanding. It could be due to past sexual trauma. Another one is vaginismus. It's involuntary muscle spasms of the outer third of the vagina interfering with sex. So penetration is not possible. So this might be something that you see in someone who's been sexually assaulted. And then hypoactive sexual desire disorder. No desire at all to have sex, low interest in it, doesn't want it, pretty much doesn't participate in it in any way. And sometimes that might have to do with sexual abuse as a child. It could be that the patient was brought up, or individual was brought up to believe that the sex act was dirty because of a certain religion that they are. So these are some factors contributing to sexual disorders. Physical trauma, abuse, sexual abuse, rape. The individual was taught sex was dirty. Childhood sexual abuse. And lack of sex education. So these are some of the actual factors that contribute to these disorders. Now we've talked about alcohol and cocaine and addiction. Now we're going to talk about sexual addiction. Believe it or not, I never thought when I went to private practice I would have so many sex addicts in my practice, but I had lots of sex addicts in my practice. And they're generally going to be men. One of the things about these patients is they, as you can see, they start engaging in more sex than intended, and they begin to develop tolerance, just like an alcoholic does. When one person is not enough, then it has to be another person and then another person. So they develop tolerance where they don't get the sexual high that they want. So they're doing it more than they should, or they get to the point where they might actually try to rape somebody in order to get that sexual stimulation. So people who are sex addicts, we treat them the same way we treat someone who has a drug or alcohol problem. So instead of going to Narcotics Anonymous or Alcoholics Anonymous, they go to Sexual Addiction Anonymous. So it's a support group for sex addicts. And believe it or not, some of these SAA groups take place in churches. The churches will let them come and use their building as a support group. So just like any addiction, sexual addiction is very time consuming. So their ability to perform their natural roles in life, be a father or so forth, isn't going to happen because they're too busy trying to figure out who they can go and have sex with. So they're actually addicted to it. So these patients, SAA is designed in the same way that Narcotics Anonymous and Alcoholics Anonymous is designed. So it is a 12-step program. And we have hospitals in the United States that are specifically for sexual addiction. person that, for example, has, if you think about nursing diagnoses with these disorders, if a person is struggling with their sexual identity, in other words, they were born male, but they see themselves as female, we would give them a nursing diagnosis of disturbed personal identity. That would be definitely a diagnosis. These are in your book on page 451. Another one is ineffective role performance. Sexual addicts often can't maintain work, family, and other responsibilities because they're out there like a predator looking for sex with whomever will have sex with them. Risk for violence, self-directed or other-directed. Autoerotic asphyxia would be risk for self-directed violence. They could actually hang themselves. Risk for other-directed violence would be if I'm trying to strangle somebody while having sex with them, I could actually kill them by accident. Knowledge deficit. This is where a person grows up and they've not had any type of formal or appropriate sex education. Okay, so a lot of health professionals deal with sexual health and sexuality on a daily basis. So according to the Placid model of addressing sexual functioning, it's believed that nurses should be able to do the top two rungs of the upside down triangle. Give patients permission to raise sexual issues. So you should be comfortable talking to them about those kind of things. And giving patients then limited information about sexual side effects of treatment. So according to that model, you should be able to be comfortable doing those two things. You can, definitely work on specific suggestions or intensive therapy, but it is just expected that definitely all nurses should be able to do permission and limited information about medications and things like that. Questions about this group of folks? These are the nursing care plans and goals for these patients. The major goals for sexual dysfunction, gender dysphoria, and paraphilias are the client will resume sexual activity at a level satisfactory to self and partner. Client will express satisfaction with own sexuality pattern. Client and partner will express satisfaction with sexual relationship. Client will demonstrate behaviors that are appropriate and culturally acceptable for their assigned gender. Client will express personal satisfaction, feelings of being comfortable in their gender. and client will interact with others using culturally acceptable behaviors. So another thing that we also want them to be able to do is we want them to be able to live within the transgender world and to make it out there with whomever they choose to be. And y'all can read over the nursing interventions. I've got those all out there outlined for you. Determine what the stressors are. When was the onset of the problem? Note any kind of, identify factors that affects the client's sexuality, like, for example, note any cultural, social, ethnic, racial, and religious factors that may contribute to conflicts. You've got to form a therapeutic relationship with these patients, just like you do any patient. Be accepting and non-judgmental. So the patient is more than likely going to be more willing to share with you information if you are non-judgmental. So what would you say to a patient that was a sex abuser that asked you, what do you think about the fact that I abuse children? What are you going to say back to that? Yeah. But this is also another good comeback. You can say, well, yeah, I mean, you brought it up, so it sounds like there's something, so you might want to talk about it. But how I feel and how you feel is different, and what I'm most concerned about is how you feel about it. See, that's what we're most concerned about, is how you feel. I feel comfortable talking to you about it if that's what you would like to do. Which I'm sure none of you want to do, right? It's not easy, I will tell you that. Okay, let's talk about them. Okay. So we're going to talk about anorexia and bulimia. Here are your early signs and symptoms of anorexia and or bulimia. This is what will clue in a parent that something's wrong. They're withdrawing from family and friends. There's a change in their eating habits, and by that I mean they eat alone, or they hide their food, or they're very depressed. Body insecurity, they have a negative and obsessive thought about their body and how it looks, its size, its shape. So they're overly focused on their body. So they have that body insecurity, and everything is totally focused on their body. You know, am I thin enough? Am I fat? Is there fat here? Is there fat there? What's my shape look like? Am I thin enough? And we begin to start noticing a change in their appearance. And generally the change in their appearance is going to be a physical change. So those are just some of the signs and symptoms that would clue us in that someone might be starting down this path. This is a path we don't want someone to start down. Let's look at anorexia first. Anorexia has the highest mortality rate of all mental illnesses. The highest mortality rate. basically because they starve themselves to death. And the problem is that they're never going to reach a level where they're thin enough. So this is where the patient loses anywhere from 25 to 50% of their body weight. The thing that's so hard to treat is their body image disturbance. So even if I'm 5'7" and I weigh 90 pounds, when I look in the mirror, I still see fat. I still look at myself and think that I'm overweight. So they have a fear of gaining weight, and they have very peculiar food handling behaviors, where they might cut things into small pieces, rearrange them, not let them touch, try to hide the food. So they're so fearful of fat that if they perceive, and that's the big word here, perceive, if they perceive that they have overeaten, they're going to punish themselves. And that's usually through purging. And that's usually through purging with vomiting, or it's purging with laxatives, or it's purging with diuretics to get the weight off. One thing to always remember about these patients, they're extremely hard to work with. They are rigid. They're obsessed. They're sneaky. And they lie. So they're just a great group to work with, can't you tell? Most commonly seen in Caucasian females. Why do you think? I had lots of anorexics, but I never had an African American. Does anybody know why?
They think they're supposed to look like the supermodels on TV that's thin, I guess.
That's exactly right. White women are raised to believe that they're supposed to look thin and beautiful.
We're supposed to be thick, big thighs say lies.
Sick thighs say
Thick
thick.
thighs say lies.
There you go. See how you're raised. See how you're raised impacts you? Their personality is a need to please, and their major issue is control. Some of the problems that we see with them would be things like if you lose so much weight, too much weight, you develop something called amenorrhea. And amenorrhea is when you lose 3 consecutive menstrual cycles. Constipation, they're going to have loss of bowel motility because they're not going to have a bowel movement. They're too busy vomiting all their food up. Peripheral edema due to lack of protein in kidney and electrolyte problems. So these patients are basically at death's door. I had a patient with osteoporosis at the age of 16. Low estrogen, dysrhythmias, hypokalemia. Why? Because they use laxatives and have diarrhea. They vomit and they use diuretics. Lanugo. Lanugo is that fine, furry little hair that forms on your skin as a way to protect yourself. So they have that fine little hair that's on their skin that they will develop. They're perfectionist. They have hypocalcemia, hypothermia, and they are a walk-in medical nightmare. bradycardia, hypertension. Because see, what's happening is, for those of you that have had nutrition know this, that when I burnt all my fat, the only thing left to burn from that point on is muscle. And one of the muscles that they start burning is their heart. So it's cardiac muscle. Impaired renal functioning, their kidneys just shut down. And they also become dehydrated. Hypothyroid problems is that they have starvation slows down thyroid functioning. Leukopenia, they develop that due to decreased intake of B12 and folate. So they're extremely malnourished. They're anemic. They have elevated BUN because they're dehydrated, impaired renal functioning. They also have, and you wouldn't think since they're eating, but you wouldn't think they'd have increase in their serum cholesterol, but they do. And the reason they do is because when a person is malnourished, it impacts how the liver metabolizes cholesterol. So they just have bunches of medical stuff going on. So these patients lose their weight through excessive exercise, not eating, vomiting, diarrhea. Anything to get the food that they've eaten out. So the nurse is always, one of your jobs as a nurse with working with patients with eating disorders like anorexics is you have to stay with them while they eat because they'll hide the food. You also have to pat them down before you weigh them because they'll put stuff in their clothes to make them weigh more. You have to you cannot allow them, or you have to set limits on exercise. They cannot exercise at all, so you have to be firm and say you can't do that on the unit. Now, so you have your anorexic, it's very thin, they're vomiting, they're not eating anything, they're a perfectionist. And then you have the bulimic. The bulimic, when you look at a person with bulimia, they are either of average weight or above weight. So when you look at them, you're not going to know they have an eating disorder. It usually is going to manifest itself later than anorexia does. It's interesting because with bulimia, one thing that's common for us to see as comorbidities is substance abuse, shoplifting, and self-injury. When they binge, they could binge up to 10,000 calories in a sitting. So they could binge up to 10,000 calories in a sitting. And they also have a cycle. So they also want to lose weight, but they're not as good at it as the anorexics are. The anorexics are great at losing weight. So these people try to lose weight. So they put themselves on a strict diet, as you can see up there on the cycle. They begin to feel a lot of tension because they're very hungry and they start craving food. And so instead of just normally going in there and getting a normal meal, they go in there and they binge 10,000 calories and can't stop. So they're pushing it down and eating it as fast as they can. Then after that, they feel so bad about what they've done, they got to go vomit it all up. So they purge to avoid weight gain. So then after all the purging is over, they feel shame and disgust about their whole process. and then the cycle starts again. So there are patients that this is all they do, y'all, all day long. It's this cycle. All day long. This is what they do.
I don't think that would be that she would eat and then she would go vomit all over it.
Mm-hmm.
She would do that like every week.
Mm-hmm.
She
Yeah.
would eat like a whole bunch and then
Vomit it up, yeah.
Sometimes your body intake the calories as soon as you eat it anyway, so.
You saw what now? Say that
Will
again?
your body not already intake the calories as soon as you eat it? Or do you, how long does it take in the body for it to realize how many calories you're gonna eat?
Well, first of all, it's going to have to be metabolized in order for you to gain weight. So that's why they vomited it up, because they're getting it before it ever got to that place. Because see, you have to wait till it's digested and absorbed, and then when that food is turned into energy, that's the calorie. So it's a process before you get there. So they're getting rid of it before that process ever starts taking place. Okay, so your bulimics is a serious, life-threatening, also eating disorder. To look at them, you might not think they have bulimia. They eat large amounts of food, as we just talked about. These are the ones that will, along with the anorexic, will force vomiting. So it's not uncommon for you to see on their knuckles calluses where they've stuck their fingers down their throat so much that they now got calluses on their fingers. Dysrhythmias because they have electrolyte imbalances. Constipation because of low bowel motility. Hypokalemia and hyperkalemia due to diuretics, vomiting, and laxatives. Dysrhythmias, electrolyte imbalance. If you vomit and carry on like this, you're going to get an electrolyte imbalance. Sometimes it's the dentist is the first person that recognizes that he might have a bulimic or anorexic because their teeth are starting to rot out because of the acid from the stomach. And their parotid glands are enlarged from the vomit. Their urine output is decreased. Their urine is generally going to be extremely concentrated. They're going to have an increase in their temperature because their thyroid's all messed up. Poor skin turgor. Now, I think you should have this handout. Get it out of my packet here. I think I handed it out on the first day. You might want to check and see if you've got that. You got it? Okay. So you might want to take it over and kind of look at it as far as some of the differences between the two, between anorexia and between that and bulimia. Now, a lot of people say, well, why would these patients have edema when they're not eating anything, they're vomiting everything up, right? Well, the reason they have edema is because of vomiting, what happens is the kidneys start to retain salt and water to try and manage the patient's blood pressure.
Did they try to retain salt?
I'm sorry?
You said the kids try to retain salt?
The kidneys are trying to retain salt and water to try and manage the patient's blood pressure. Their lungs can become damaged because they vomited so much. Your anorexic's gonna have dry, brittle hair, low blood pressure. You're gonna have the lanugo, blue fingernails, stool retention. It's all on your handout that I gave you. Another thing that your bulimic is going to have is you might notice that they are very hoarse and have esophagitis or dental erosion because they vomit so much because they're in that cycle. They are going to be constipated as well because they have no bowel motility left. They've lost it because everything else is coming up. Again, dysrhythmias because of electrolyte balance, fluid volume deficit. I mean, they're medical nightmares. So these are these people. These people might be somebody you get on the med surg floor, or you get in intensive care. These are people that we can court order for them to be tube fed, and you're going to be lucky enough to be the nurse, and they're going to be trying to pull out their tube. So you get to deal with that. They are a hard, I'd rather deal with schizophrenics. Just put it to you that way. You give a schizophrenic, like I said, a honey bun, and set them in front of the TV, and they're happy. Okay? Not these people. And they're going to hate you too, I'm telling you. They're not going to like the nurse. So it's very, because you have to set limits, see? But you have to develop a relationship with them or you're not going to get anywhere. This is one of your most difficult populations.
Since you have to sit with them when they eat, how long do you wait after the meal?
You need to sit with them for at least an hour. So after eating, they cannot go to the bathroom for an hour. They also cannot do any type of exercising on the unit. You have to check them to make sure they haven't weighted down their pants before they're weighed. So they're real sneaky. Then they'll try to sit instead of eat their food, hide it and scrape it into their lap and stuff like that. So there's the sheet there, and it's on your slide. And we're going to stop here today at nursing interventions and pick up here on Tuesday. He thought bipolar disorder was bad.
I didn't do it.
What?
I didn't do it. It just had a lot. I got you. Maybe I should.